We'll talk about the current status of resurfacing, how it compares to total hips, and then the advances we've made over the last 20 years of doing this. They've really been pretty dramatic advances in resurfacing. We've really improved it, and we're still we're definitely, those of us who do resurfacing, the outsiders in the joint replacement world. Most of our colleagues think what we're doing is silly and doesn't work, and this whole lingering. It used to be the others would constantly talk about the chance that you get cancer with these metal bearings. That fortunately has faded away because it was nonsense all along. There's good evidence that there's no carcinogenicity with these ions. But now, the last 10 years, it's all been about ions and toxicity and inflammatory problems in the hip, and so they exist, and we'll talk about that. But they're pretty rare and they're very preventable. All right, so we're going to get started now. I was trained at Hopkins, and I did joint replacement fellowship out in California, where I grew up. And then I was practiced out there for a year, and then I came to Columbia, South Carolina, a little town of about 700,000 people in the Midlands of South Carolina. And I've been in a private practice group here for 26 years. And but I do enjoy academic work, and I do a lot of research, as you all know, and out of private practice. I prefer that to being at a university where there's a lot more red tape. I started resurfacing in 1999, about 5 years after I got here. I saw the early work that Derek McMinn was doing, and I was intrigued by it, and I started doing them as custom implants before they were available generally here, but you could get around the usual regulations by using a custom implant. So I did that a little bit, and then we decided, this seems very promising. So I got together with Corin, and we started a trial in the U.S., and went from two to 5. And that went pretty well. But in the meantime, I was interested in mainly an uncemented femoral component. I didn't think it made sense to cement femoral components when we were already doing uncemented total hips in young people. So I convinced Biomet to develop an uncemented implant with me. And the first cemented one came out in 2005, and the uncemented one finally in 2007. So about 5 years after I started the Corin trial, we finally had an uncemented implant. It took a while to develop that. And in most recent advances, we're now doing almost all these as outpatient surgeries. We've perfected the technique. We don't even need the hospital anymore. To date, I've done about more than 6,000 resurfacings. Most of them are the uncemented since 2007. And, recently, they're all outpatient. 80% are outpatient surgeries now. The history briefly of resurfacing, goes way back to the 50s. But in the 90s, Derek McMinn and Ronan Tracy in Birmingham and Harlan Amstutz in Los Angeles pioneered metal-on-metal resurfacing, piggybacking off some of the earlier work on metal total hips. I got intrigued by that. As I said, in '99, I started just tentatively doing a few of these as custom implants. The first large cohort was the FDA study, which I was the lead investigator, did the most implants. And those people have all, well past 10 years. So we have an actual 89% 10-year implant survivorship. So that was pretty good, better than total hips in young people, but not as good as we are now. And you can see the improvement since 2007. I've been doing uncemented ones, and we've gotten it down to now 99% at 10 years. So a tenfold decrease, 10-point drop in the percentage of failures by 10 years. That's pretty dramatic. So you can look at that two ways, or you can say 11% failure to 1% failure. An 11-fold drop in, virtually no failures anymore. It's very small, and this is since 2009, the uncemented implant. So let's just drop back a second and think about how we measure success. Implant survivorship is what I just talked about, and that's how orthopedic surgeons like to talk. It's pretty cut and dry, and so you can compare things pretty easily. And so we focus mostly on implant survivorship. But I think even more important than that is probably its function, and that's why a lot of people want resurfacing, because the function is better. It's harder to measure, it's harder to compare, and so we, in the orthopedic world, we tend to give that a second level of importance. We mostly just talk about implant survivorship, and there's those that are leaders in the field. That's all they want to talk about, and if you have better implant survivorship, that's what everybody should use. And to me, that doesn't make any sense. There's other factors too. There's residual unexplained pain with hip replacements. These are not perfect. We don't make a normal hip. So which one gets closer to a normal hip? Which one do you have less residual pain with? Hard to measure because pain is very subjective. But it's been done, and we can talk about that a little bit. Bone preservation is often mentioned. That's a secondary importance, I think. If you have a real durable implant, it lasts a long time, it doesn't matter how much bone you preserve. But it is also important for a number of reasons. There's other complications that we need to talk about. It's not just how long the implant survives. There's complications that are different with the two implants. And in the last 5-10 years, we've learned that patient lifespan, so not the direct risk of dying from the surgery, but the long-term lifespan with one implant and another is different. So we'll talk about all those, but we'll start with implant survivorship. And so first we have to talk about how do we define failures. Generally, it's any implant that's revised for any cause. Now, sometimes people will try to game this a little bit and say non-septic revision. So they exclude their infections because it's not a mechanical problem with the implant. No, that counts. You got to put everything in. Otherwise, you can falsely make your results look better than someone else's, right? So you got to look at for all revisions. If any paper tries to say we're looking only the femoral component or only the acetabular, that's nonsense. It's worthless. It's the whole implant. And sometimes you should also include failed implants that are not revised. So these do not get counted in registries because only people who get revisions count. But in series like mine and other surgeons, if the implant has failed but the patient chooses to live with it because maybe they have a heart problem, they don't want a revision, that's still a failure. Okay, and that's a radiographic failure. And then there's something called clinical failure. The x-rays look perfect, the implant hasn't been revised, but the patient's still having a lot of pain, you can't figure it out. That should be probably used, but it rarely is, because the patient could be having a back problem or a tendon problem. So in some cases, you'll see that used. All right, then there's actual survivorship, like in my corn series. All the patients have made it at least 10 years, so you can look at how many made it to the 10-year mark, and that's actual implant survivorship. That's the best, but that's impractical because in most of our series, we're still doing these operations, and you want to include the whole batch. So you do what's called Kaplan-Meier estimated survivorship, okay? And so generally, you'll see survivorship. When people say survivorship, they mean Kaplan-Meier survivorship, and then usually somewhere in the paper it'll be pointed out. That's a statistical method. It accounts for losses of follow-up, patients who've died, patients who have 5 years of follow-up, 10 years, and you get a survivorship for the longest follow-up. So if I start doing this in 07, I now have a Kaplan-Meier survivorship of 13 years when I put all the numbers in and calculate it. Okay, so that's some of the background you need to know about how these things are done. Of course, all implants fail. There's no perfect system, and they don't reproduce a totally normal hip, so there's some residual pain in a certain percentage. And the failure rate increases with time, of course, right? The longer you go, the more failures pile up. So the time of follow-up in these studies is critically important. And then there's risk factors. There's factors that are known to cause a higher failure rate. So you can game the system again by saying, well, our survivorship in osteoarthritis, you exclude dysplasia and necrosis. Well, those are always going to come out worse, have a higher failure rate. So you can game the system by just saying osteoarthritis, you're going to have better results, right? So something to be aware of. Patients with younger age have a higher failure rate. That's well known, and that's what we're focusing on in resurfacing. That's why we specifically focus on this, because the total hips have a higher failure rate with younger patients. Resurfacings don't. And for resurfacings, females have a higher failure rate, or used to. But total hips, it's pretty close. In some registries, men, sometimes women, have a slightly higher failure. They're pretty much the same with total hips replacements. But in resurfacing, it's quite different. People with weak bone have more failures, more fractures. People with severe erosions, really bad arthritis where bone loss, those are more difficult cases, right? Obesity have higher, people who are obese have a higher failure because they're harder to operate on. It's harder to get to the hip, harder to get things implanted properly, and they also have a higher infection risk. And all things that cause higher infections can cause failures of the implants. If it gets infected, you have to take it out a lot of times, right? So all these things can impact the survivorship. So, every series can be a little different. That's why it's hard to compare different series, because there's so many different factors. So let's look at general implant survivorship. There's 3 major national registries that are good. Okay, we've explained how we measure success in different ways, and now we're talking about implant survivorship. And the 3 registries here, I think the Australian is the best. Then there's a British and the Nordic, but they have their limitations. They measure only cases that were revised. So if a failed implant, the patient's, let's say, too old to have a revision, they still count as a success. But they have an implant that's loose and they're limping around, they can't walk, right? It's a failure, but they don't count. They're still counted as a success by our survivorship. Not in my series. In a personal series of a surgery, you wouldn't count them. You'd count that as a failure. And some cases aren't entered. I mean, it's a national process. Surgeon's got to fill out a form and send it in. So there's a certain percentage that don't get put in. And then when someone has a surgery and then let's say in Colombia, and then they have a revision in Los Angeles, those have to be linked. Or this is not done in the U.S. Let's say in London, and then they have a failure in Birmingham. They get revised in Birmingham. Those have to be linked in that. So there's problems with linkages sometimes, and so you're just not 100% sure how many have failed really. A big difference with resurfacing total hip is that when there's a fracture early in the time period with resurfacing, they need to be revised usually to total hip. In total hips, they get repaired with cables, plates, and so forth oftentimes, so they don't count as a revision. So that's a success for a total hip, but it's a failure for resurfacing. So you've got to look at that also when you look at registry data. And so they're not always very comparable, but it's very useful as a rough benchmarking tool. And most importantly, what you have to realize with registries, it measures average surgeon performance. So someone who does 2 resurfacings a year, their data goes in there, and someone does 500 resurfacings, their data goes in there. Well, guess what? With resurfacings, there's a lot of surgeons who do 1 or 2 or 3 here or there. With total hips, there's a lot of surgeons who do a lot more, right? It's more consistent and people have been trained with it. So registries are not really a fair comparison of what can be achieved with resurfacing or total hip replacement. The average surgeon can't do as well with a resurfacing as a total hip replacement. And so you have to think about that. All right, so here we go. With that preamble, we'll get to the registries. The Australian Registry 2019 is the latest report. And here's at the 10-year mark, this is failures going up. And the resurfacing has at 10 years, 9% failure rate in resurf and a total hip. This is all ages, only osteoarthritis diagnosis, all ages, and both genders, and of course, all surgeons in the country. So the average surgeon at 10 years, has better implant survivorship with a total hip replacement. Their resurfacings may be functioning better, but they fail earlier. All right, onwards. Also in the Australian Registry, here's the difference between men and women. 18% failure at 10 years versus 6%. This is the average surgeon in Australia. And you see the bars continue to worsen. So women definitely have a higher failure rate with resurfacing in the general registries. The Swedish Register is the other good register, sometimes combined with the Norwegian and Danish to make the Nordic Register. Didn't in the last report, didn't report any age related, but their overall total hip implant survivorship, 4 and 6%, similar to what you see in Britain. So the average Swedish surgeon seems to be just as good as the average Australian or English surgeon in doing hip replacement. Well, there was one analysis of the registry. So this is not the registry report, but someone who got the registry data and analyzed for young people under 50. And this is what they found: 83% 10-year implant survivorship, so 17% failure. So if you take very young people, a much higher failure rate than what you see for total hip replacements in the general age group. But so that's what the average surgeon can achieve. So let's see what can expert surgeons achieve. So we tried to get away from this idea of using registries for resurfacing data, because there's so many surgeons who do so little and their results contaminated. So we included 28 surgeons internationally in this study. This hasn't been published yet. We're trying to get it published, but the study's complete. So we looked at 28 surgeons worldwide, and we have 11,000 patients under 50. So we take the hardest group, the one with the highest failure rate, because we know we're going to do better than a total hip replacement in this group. And this is the data. For all patients, it's 95% at 10 years. Remember, I just said it's 83% for total hip in the Swedish registry, and 90% at 20 years. So in the Swedish registry, if you dig it out, it's 50%, right? So dramatically better. Zoom wants to give me a gift. Men, again, are better than women. But notice, women are better than total hips. Young women have better outcome. Even though they're worse than men, they have better implant survivorship. So careful when I use the word outcome, because, again, there's different ways of measuring outcome. But implant survivorship, even in women, is 81, 50 at 20 years. Is better than total hip replacement in the young patient. All right, so that's a whole group of us who all basically say we're resurfacing surgeons, and we got together and put our data together, right? So we exclude all the people who just do an occasional smattering one here. What about individual surgeons who've published on this, okay? Ronan Tracy, famous surgeon. There's results, my results. And Kim and Belay from Canada, Mr. McMinn, of course, stellar outcomes. Amstutz is not quite out, only 5 years, and Peter Brooks only out to 5 years. So I weighted these and added them together by weighted averages, only the ones that are 9 and 10 years. And so those are the numbers. Well, so So I've just talked about what can be achieved by expert surgeons in resurfacing, and we're comparing it to the registry. Well, that's not really fair either, because the total hip surgeons are expert ones who do better than the average ones. I think the spread is not as big as in resurfacing, but so what can be achieved by the surgeons expert at total hip replacements? Those that publish on patients in younger ages. These are all the papers I could find that gave implant survivorship out, to 10 years. And again, Peter Brooks has one, but it's too short to really include. And I weighted, averaged them, and we're gonna go to the next page. And here we put them side by side. Okay, so we've got about double as many resurfacings in these reports as the total hips, and the implant survivorship is 5 points better, right? Significantly better. Even experts at total hip and experts at resurfacing in young people and slightly longer follow-up. What about the best of the best? McMinn has the best outcomes, and Walter, Bill Walter and Sydney, ceramic on ceramic total hips. He's the best, has the best outcomes published in total hips. Only a quarter of the patients. A little bit older group, not quite as good. Still, even at the very top of the top, the resurfacings come out on top for young people. Okay, so the average surgeon can do better with total hip replacement, but expert surgeons at hip resurfacings do better than experts at total hip in patients that are younger. And here's some benchmarks. Total hips, again, just to summarize what we've gone through. 95% 10-year implant survivorship from registries. This is a round number. Hip resurfacing, 91. The average surgeon, 91%. Not so good. Total hips under 50, only 80%. Experts with total hips under 50 getting up to 91%. Experts with resurfacing, 95%. Okay, so when you summarize all this, it looks like if you take into account expertise, if you get an expert surgeon, you're going to do better with as far as implant survivorship with resurfacing, if you're a young person. The results with resurfacing don't change with age. They do change with total hips. So the survivorship gets better with total hips. So as you get older patients, the numbers get closer together. The total hips draw closer to the resurfacings, and there's less difference. That's why we chose the younger patients, so we could show the difference between a resurfacing and total hip. All right, so we've beat implant survivorship to death, and I've shown you that resurfacing is better for the young person, and even for women, young women. So now we're going to move on to function, which I think is even more important. Clinical scores are generally not sensitive enough. We have the Harris Hip Score, the Oxford Hip Score. We have various different kind of scores, but the bar is not high enough. If you can walk a mile and play golf and have no significant pain, you get 100 Harris Hip Score. You got a perfect Harris Hip Score. Well, that's not good enough. You can't. That doesn't mean you can run and jump and play and do athletics and do heavy labor. So clinical scores are basically worthless to try to measure a difference between resurfacing and total hip. Gait studies. You can walk in this rig in a lab, but you can walk and you can walk fast. So what about walking? With walking, can you measure a difference? Yes. 3 surgeons have done this and have found that resurfacing is superior. There have been no studies that show total hips are superior. There's some that show they're equal. But usually the resurfacing comes out on top with fast gait. So it's slow gait, you're equal. Fast gait, you do better with a resurfacing. Then to get at higher levels of activity, you have to ask more higher level questionnaires about activity and sports, and you can make standardized questionnaires and give them to people. And these have been done by 3 investigators, and where resurfacing has come out on top. There's others where they're equal again. And then Faris Haddad in London tried a randomized comparison study, but it wasn't perfect because a lot of people changed their mind and decided they didn't want to be randomized. But in the randomized study, the resurfacing came out on top as far as function. So overall, I have 15 papers in my database that compare function, and some show that resurfacing are superior and none show total hip replacements are better. So why is function better in resurfacing? Because it's pretty basic. The resurfacing reconstructs the hip more naturally. The natural biomechanics. You just have to look at it. You don't have to do a fancy study to see that it's more like a natural hip. Total hips have a smaller head, so they have a higher instability rate. And total hips load the shaft of the femur. That's the real problem with the running and all heavy labor and very vigorous activities, because that causes thigh pain. And 2 to 5% have moderate to severe thigh pain. They have a limp with fast walking, the gait studies show, and they're unable to run well. Then there's this impingement problem. So with a total hip, the stem will impinge on the cup if you bend far enough. And that will cause levering out or instability, but it won't cause pain because it's a component on component. With the resurfacing, the neck of the femur is still there, so it'll hit the edge of the cup at some point, And that can cause groin pain with hip flexion, right? So you might see in some studies a little bit more groin pain with hip flexion. And that I think is a neck on cup impingement problem. Then you got this problem of psoas tendonitis, which is hard to sort out from impingement because it also causes groin pain. But this can happen equally with a total hip and a resurfacing because the cups are equal size. If I do one patient a total hip on one side and a resurfacing on the other, I'm going to use the exact same outer diameter cup. So it's the cup hanging over the edge, rubbing against the psoas that causes this problem. Very difficult to sort out because there's no specific diagnosis for it. It's a clinical diagnosis. But there's no reason to think that's any different between a total hip and a resurfacing. It's a matter of surgical technique, implanting that cup so it doesn't rub on the psoas. And, we've been doing that now for years. We've figured that one out a long time ago. So that problem is anybody after 2007 really doesn't have that problem anymore in my practice. So in my practice, just anecdotally, 40% of my patients choose to go back to impact sports. Some people, that's not what they want to do. And they can still have a resurfacing. It's not only for impact athletes, but 40% go to impact sports and only 2% have moderate or greater unexplained pain. In total hips, rarely do they go back to impact sports, and a lot of studies show 10 to 20% have at least moderate residual unexplained pain. It's usually thigh pain from that stem with higher activities. But that's not scientific. That's just my anecdotal personal data. All right, bone preservation gets talked about a lot, and it is important, but really a lesser, a secondary factor. Ed Su did a nice study on cadavers, and he demonstrated it. There's no difference in socket bone removal. You can see a total hip and a resurfacing. No difference in socket removal, but definitely you take a lot less femoral bone out. So how's that important? Well, when you do a revision, taking the socket out and putting a new one on, you're going to encounter the same problems with a total hip or a resurfacing. But if you need to revise the femur, here you just chop the neck off, and that stem just pulls out, and you got a primary femur to put your stem for a total hip replacement in. Here, if that has to come out, that's bone ingrown at least down to here. You damage the whole top of the femur trying to cut that out. These are really hard to get out. Sometimes you have to split the femur, open it up, and then take it out, put a longer stem in, and cable everything around it. So much more difficult to revise the femur if you got to do that. For infection, you definitely would have to do that. Okay, so there's other issues. There's not just function and implant survivorship. There's also reoperations and complications. Generally, they're about the same. If you have to clean out an infection, those infection rates are no different between resurfacing and total hips. We talked about fractures. Fractures are handled differently. So fractures on resurfacing are usually neck fractures. You cut the neck, trim the neck, and you put a stem in. Pretty straightforward, but it's a revision. In total hips, you sometimes have to cable and put the implant back in, and that's not counted as a revision. Sometimes you do put a longer stem in, so that would be a revision. So they're not always revisions, they sometimes are. And they're equally difficult to get over, actually harder to get over than changing to a stem, in my opinion. Other complications like nerve injuries, blood clots, there's no evidence that any of these are different between the two operations, but dislocation certainly is. 10-fold higher dislocation rate for total hip replacement across the board. And then there's medical complications, which we don't need to get into, that don't affect the implant itself. All right, in the last 5 or 10 years, we found another very important difference between these two implants. And this tends to be swept under the rug, although there's been now several studies published on this. The way we look at this is what's called all-cause mortality in registries. So in the Swedish registry, there was a study done looking at, and there have been several of these studies done looking at, how does total hip replacement impact the overall lifespan of a patient. And it seems to improve the life expectancy of a patient. So in the first 30 days, you have a slightly higher mortality of a total hip replacement. But then if you get out to 90 days, compared to a person who didn't have a hip, you already have a lower chance of being dead, right? So doing an operation gives you a slight early chance of dying, but by 90 days, that's erased and you're back on the positive. And if you got to the long term, 10 or 15 years, you have about a 30% lower mortality than the general population. And there's lots of theories of why that might be. But so in general, total hip replacement improves your chances of longer term living longer for some reason or another. Well, what about when you compare total hip resurfacing and total hip replacement? McMinn was the first one to do this recently. I don't know how he came onto this. But he looked at the British Registry, not his data, the British Registry. He got the data and he evaluated it, but he only looked at men, BHR in men. And of course, the comparison group were similar aged men with total hip replacements. And there was a 60% difference, 8% 6-year mortality in the BHR and 13% in the general. So markedly better 6-year all-cause mortality, chance of dying from any cause. Well, Kendall looked at this a little bit more closely, and notably, he's from Oxford, where they do a very poor job of resurfacing, and they're anti-resurfacing almost. And he looked at this data, and he did more controlling for comorbidities, rurality, area deprivation, which means areas that are poor, surgical volume, so forth. I did all the comparisons that he could that are available, and pretty extensive controlling, and still found a 20% lower mortality at 10 years for resurfacing. So here's the chart out of the Australian registry. So they only control for age and gender. So we're not comparing young resurfacings against old total hips. We're young people against young people. So if you have a resurfacing, look at the dramatic difference in the, this is 14-year survival. This is not implant survival. This is your survivorship. Pretty dramatic. The only thing that I can say is that there may be some selection bias in those who choose resurfacing. They might be more, healthier people, but Kendall accounted for that. He looked at comorbidity. That's the Charleston Comorbidity Index. And it also may be that people who have resurfacing are able to run and jump and exercise where total hips can't really do it so well. So that improves their survivorship. That's speculation. But there's no doubt there's a difference in survivorship, no matter what the cause is. All right, so now we're going to shift gears. We just kind of talked about the pros and cons between resurfacing and total hip replacement. Now we're going to talk about, that's kind of the current data. I'm going to go back now 20 years and take you through my experience of doing resurfacing and how we've gotten better, because I've clearly gotten better. And I'm sure most of us who do this on a regular basis have gotten better, but I've got my data. What showed you earlier, 10 percentage point improvement over the 18 years I've been doing this, or 11-fold difference. Now I'm going to try to tell you how this came about. So when you make improvements to an operation, you look at the various different failure modes individually, and then you try to figure out, some strategies to address those and see how you can improve your results, and you test them. And if you keep your data, then you can even see small differences. If you're just doing operations, not keeping track of data, it's hard to notice very small differences. But if you have large numbers of patients, you keep your data, you do statistics, you can find small differences, and they add up. You look at all these different problems, all these improvements, and they add up to a huge improvement. All right, so we're going to go through each one of these. Early femoral failure are fractures in the first 6 months and head collapse. I think they're kind of the same process. That's why I lump them together. Failure of bone and growth of the socket, and then adverse wear, meaning these metal ion wear problems. Acetabular loosening. So the socket can grow in, but then it can become loose later. So any failure after 2 years I call a loosening. It's attached, but then it's come loose. The femur is initially fixed, and then it comes loose with time, either cemented or uncemented. Then we're going to look at two special high-risk groups, dysplasia and necrosis, and how we've made improvements there. I'm going to look at post-op infection, because this is what a surgeon has control over. And then there's late infection, which we don't have control over the cause of this. This happens to people, and I have no control over this. But we do have a control over how we manage this, and maybe we can save the implants. And then we can look at instability. All right, so we're going to go through these one by one. Early femoral failure. Initially in my practice, 1.5%, now 0.32%. So it's an 80% reduction. This is statistically significant because I have large numbers. So we did a study at first to look at why we had fractures and did a risk factor analysis. We found that low bone density and obesity. So if you're bigger, you're going to load your femur more in that early post-op period. Sometimes it can't handle it and it breaks. And if you have low bone density, of course, that's logical that you should have a higher risk of fracture. These are the only two factors that are significant. So what did we do? We started giving bone strengthening medicines, bisphosphonates, and we started keeping people who are higher risk. We measure all their bone densities beforehand, keep them on crutches longer. What did we achieve? We achieved a reduction. We've published this as well. Okay, so these are two papers, risk factor analysis, then analysis of our initial treatment, and we've shown that we can reduce it. So fracture rate is 0.32, a third of 1%. There's also this idea, the approach, the way you go into the hip, damaging the blood supply to the femoral head, and that affecting the fracture rate. And so we all were kind of amazed early on that DeSmet only had 1 in 1,000 fractures, where the rest of us were kind of more like 1.5 to 9%. And so we, of course, queried him about this, and he said he thought it was the way he left the tissues more intact on the neck. He called this vascular sparing posterior approach. But with any posterior approach, you're going to damage the blood supply to the head to some degree, but you can be more gentler and have more residual flow to the head. And then you do some damage and it usually recovers. But then some people end up fracturing during that time period. So neck fractures always occur in the first 6 months. I tried this after I talked to Kuhn, and we all talked about this, and I tried to do a study on this, but I found no difference. So I should have published it maybe, but I didn't, because I didn't see any difference. But I kept doing it because I think it still makes a difference. I don't think I had enough numbers really to show a difference. Ed Su did test it, and he did find a difference. In his series, he had a 5% fracture rate, fracture and collapse. I'm counting together, the early femoral failure, 5%, and he went to 0.4%. So by changing to a more gentle tissue preserving approach, he was able to show a drop in his fracture rate. I wasn't, but I still do it because I think it makes a difference, although I can't personally show it. All right, now we're going to change gears and go to dysplasia. This is the high-risk group that is the main reason why women have so much trouble with resurfacing. If you exclude osteoarthritis, all your results are better. The reasons why dysplasia patients fail are, and we've analyzed this, and these are 2 papers I've put up here that we've published on these topics. First of all, 70% of all dysplasia patients are women. 30% of the women that I do have dysplasia. So a third of the women I do resurfacing on have dysplasia. Now that's a very high risk group. If you look at results of total hip and dysplasia, they're terrible. They're not anywhere near total hips and osteoarthritis. So this is a really tough group to work on. So if we're biasing our resurfacing groups with all these ladies with dysplasia, of course they're going to have a higher failure rate. But so not doing resurfacing on them and doing total hips on them instead, I don't think is necessarily a great idea. I think it's better to figure out why they're failing and see if we can make a difference. And we've done that. So failure of ingrowth of the socket and adverse wear, because adverse wear is caused by cup malposition. So just think about this. In dysplasia, you got an oval socket that's too shallow. It's hard to fix a cup into it, and you get fooled in your orientation because it's oval. And when you don't get the orientation right, you get wear problems. Of course, before 2007, we didn't know what orientation caused wear problems. We were kind of working in the blind. We said, this cup position seems okay. Let's shoot for 45. And, you can't always hit what you shoot for. But now we have a much better idea of all this, and we'll go over this in detail. So when we developed good cup positioning guidelines, which I'll talk about later, and we got supplemental fixation cups with spikes that we could use in the most difficult of that spectrum of dysplasia, we were able to drop the failure rate of dysplasia down to 0, 9% before 2008, 0 afterwards. So we solved the dysplasia problem. And that's a dramatic reason why women are now doing much better with resurfacing. Then so some of the dysplasia cups don't get fixed. They don't ingrow because of this problem I discussed about. But other patients also have occasional failure of ingrowth. It's much lower, 0.5%. But we still wanted to try to solve this. And I had this hypothesis that maybe if you let the cup wedge in the socket more, if you take out a little bit more bone at the apex and just let it wedge on the edges, as a patient walks on it, it'll drive in there and impact harder and harder and get tighter. And we can maybe increase our chance of a bone ingrowth. Whereas if you just do it line to line, you might have it a little looser on the edges. It bottoms out and it starts toggling a little bit, right? So this was my hypothesis. So we changed the preparation method to take out a little apex bone and wedge it every time. And then we did thousands of cases, and guess what? The failure rate went way down. Went down 5-fold. So failure of ingrowth is a super rare problem now in dysplasia and in all other patients as well. Next, adverse wear. Okay, Kuhn-Desmet was the first one who figured out that that steep cups and small implants were the problem. Small implants have a lower coverage arc. It's a quirk of design, so they're more prone to being too steep. So that's why women, smaller implant sizes, have more wear failures than men. And so once Kuhn made us aware of this problem, we looked at our data. No, I'm skipping one slide ahead. So first of all, let me back up. The wear problem, it's reported at various different incidents. We've published on this, and I had a 1% wear failure by 10 years. And so that's not terribly high when you think of 5% failure overall in 10 years. 1% of those 5%, 1 out of 5 were wear failures. So, okay, it's not a huge problem. It's a problem, just like all the others we talked about that should be solved. But some people say, well, this is a horrible problem. If you get a wear problem, your muscles are going to drop off and you're going to have a horrible hip. That's what Oxford published in their revisions. But they just did a really bad job. I published on revisions of these, and they're just like any other revision. In fact, the failures of cup ingrowth are the ones that have the highest failure rate at revision. These do very well. 7 out of 7 of when I published this in 14 did fine. So you just change the cup, put a new cup in a better position. You can clean out the debris carefully. You don't cut all the muscles and nerves and arteries like they did in Oxford, and you have good outcomes. And other people, Kuhn de Smet has published good outcomes with this, and Jim Pritchett has. So you can do adverse wear revisions with the same kind of outcomes as you can other failures. So it's not a particularly bad problem. It's just a problem like all others that needs to be solved. And so how do we solve it? After Kuhn made us aware of it, we studied our group. We had a large group of patients where we had x-rays and ion levels, and then we did this complex comparison, and we figured out that if you put the cup below a certain inclination level, the inclination is how steeply the cup is tilted up. So then you don't see any wear problems when we plotted this out on a graph. But it's complicated, but it's just because it's not just one cup position for all hips. The upper limit is lower for the small cups because they are shallower. So you get a straight line graph, and you got to stay under that. So that's a little more complicated. And when you go to surgery and try to do this, you have to have the chart there, and you have to know your implant size. You put in a certain size, 46 in. That's a small lady size, and you got to get under 35 degrees on that one. On the bigger one, you can get up to 45 or 50 degrees. But as long as you stay under that guideline, we started doing this. We were able, after a little while, we were able to get it 100% of the time with an x-ray in surgery. And then we followed those patients, and we demonstrated that you can totally get rid of wear problems if you follow this. So it went from 1% to 0. Not had a single wear failure since 2009. No patient implanted after 2009 has had a wear failure in my practice. So you can solve that problem just by placing the cup properly. And more people are beginning to understand that. Not the total hip surgeons. They just don't get that. But the resurfacing surgeons who do this a lot, they understand this now. Now we're going to move to acetabular loosening. So the cup is ingrown, but then it comes loose later. This was primarily a manufacturing problem of Corin. My first company, I started noticing at 8 years, some of these cups that were well fixed and functioning well for years, guys playing basketball on them and running, suddenly the cup came loose. And it's turned out to be about a 4% problem. We've published this. We compared it to a biomet cemented with an uncemented cup group, or all the biomets now. And I've only seen 2 debondings in the biomets and 2 other loosenings in the biomets. So a very low rate. And for the Corin, it was 4%. So basically, just by moving on to the biomet implant, this problem was resolved. It was a failure of inadequate manufacturing of the Corin implant. We're still dealing with that legacy now. One of the reasons that one was not as good as other implants out on the market. Femoral loosening. This is the process I started on in 2002, and we finally have enough data. It turned out actually that cement on the femur has done much better than I ever thought it would. So cemented total hips didn't do well in young people. I was doing uncemented total hips in young people well before I was doing resurfacing, before the data showed that was better, because it just seemed like a better idea. And it just didn't make sense to me to cement a femur in resurfacing patients who were putting in young people and telling them to run and jump on these things. Well, it turned out cement has turned out a lot better than we thought, but it still has a low failure rate. In my hands, so this doesn't count fractures or head collapses in the first year or 2. So starting after 2 years, any femoral component that then failed, I would call a loosening. This is a cemented one. So by 10 years, I had 1.1%. Not a high number. Similar to the adverse wear problem. This doesn't get as much press. With the uncemented component, we've not had a single loosening. We've had some fractures and head collapses early, but after 2 years, no loosening. So once you're ingrown, you're good forever. And they all ingrow. So the uncemented implant, we've published this. Here's the publication. If you want to look it up, it's on my website. But incidentally, all of these publications are on my website if you want to go and look at it in detail. So we've dropped the failure rate another 1% here by just going to an uncemented component. So these numbers are starting to add up. Now we're going to diverge again and go to another special case, high risk, osteonecrosis. This occurs usually in men, and 70-80% of these are young men who are alcoholics. Alcoholics don't follow directions as well as other people. And they generally have a higher failure rate with total hip replacements and resurfacings because they're not what we call compliant. They don't follow instructions, just do what they want to do. And with resurfacing, we thought we maybe had a solution to that, but because there's so much bone necrosis, let me explain for those who don't know what it is. A part of the femoral head dies, and it's related either to alcohol, too much alcohol consumption, or to steroid use, high steroid use. So the ladies with rheumatoid diseases who used to get high steroids used to get this, and the men, men who treat their depression with drinking get this, as a general rule. But then there's about 30% who just get it out of the blue. But they're a tough group, and so they have a lot of dead bone in the head, and it could be a third of the head, it could be a half of the head. Usually it's not more than a half of the head, but you can imagine if you do a total hip, you cut that whole head off, and you can put a stem in. There should be no reason why that is any different than a total hip in osteoarthritis, but they do have much higher failure rate with total hips because they're young guys who are a little bit hard-headed. And so they don't follow instructions. They go out and do what they want, and total hips can't handle it. For surfacing, they fail because they have a lot of bone loss, and you're trying to fix this head onto a head that has defects. And you put more cement in it, the cement heats up and it burns more bone. So you get more head failures. So in my cemented group, 8-year survivorship was 91%. But with the uncemented group, you don't put all that cement in, you put bone graft in, and there's enough bone around the base of the head that these grow in. And we have a very high success rate. So when I published this, it was 100%. Since that time, I've had one guy who just had a femoral neck fracture. So it's now down to 99%, just like 10-year implant survivorship. We're up to 10 years now, just like all the others, all the other groups. So we've solved the problem with dysplasia. We've solved the problem with necrosis. What about deep infection? Well, this is in control. The surgeon is in control of this. Deep infection. When we operate, there's a certain rate of infection, and it varies dramatically between surgeons. It's probably underreported because a lot of infections take a while to diagnose them for sure. So I've just looked back, and we're working on a paper on this right now. So I've looked back at these early post-operative. So anyone that has symptoms or signs of, even they get revised for infection at 2 years. If they had symptoms starting at 1 year, their hip was hurting and painful, irritated, all along, they get counted as a post-operative infection. Anyone who starts symptoms after 1 year, they are assumed to have had a clean operation, no bacteria got in there, and then they got bacteria from somewhere else, a urine infection, a pneumonia, a lot of different trauma, whatever. They get an infection. So that's a different ball game. This happens, and I have no control over this. I have control over this. Fortunately, I've had a very low infection rate, 0.07%. So the benchmark for the U.S. is thought to be, I've talked to Jay Parvizi, he's one of the infection experts in the world. He says it's about 2.5% for, if you look at 1 year infection rate for total joint replacement. So being at 0.07% is remarkable. And there's a lot of things we're doing, and we're going to publish a paper on what we do to try to keep this low. But also, interestingly, you can see that of these 4 infections I've had in 6,000 cases, 3 of them have been cured. And most surgeons believe you can't cure them, that you have to take the implant out. But there are ways to cure them, and we're going to publish this. But we only have small numbers, so I don't know how believable it will be. Also, the late infections, which surgeons really feel you can't cure because they think the implants need to come out. Look, 2, 3, 4, 5 out of the 8 were cured because if you recognize them quickly enough, you can sometimes cure them with the right treatment. We put and deliver antibiotics right into the joint, and so we're gonna. This is part of the publication, looking at these 2 types of infections. So that's one reason that you need to keep in touch with your surgeon if there's any problem. And if we diagnose these promptly, we can cure them. If they linger on, the implant comes loose, then you got to take the implant out, obviously. So much better than the benchmark. I think we may be improving. And here's a graph from our paper we're just putting out. And this is each one of these is 1 infection. I mean, these are 0 infections. And you see the number of cases I did that year. These are primary hips, total hips and resurfacings. And each of these represents a percentage. So that's 1 out of 395 hips I did that year, right? So it's 0.25%. So, and then there's 0 these years. And if we do a best line fit to this graph, it seems like it's going down from 0.15 to 0.07. So over the years, we've been adding more and more different things we're doing to try to prevent infection. Maybe it's making a difference. We haven't run the statistics yet if that really represents a difference or not over the long term. Nevertheless, it's very low. And we're going to write a paper about how to cure these things as well. So what about so that's a small problem in my hands, but much bigger in total hip replacement in general. Dislocation, well, the risk is consistently 0.3% with 1/3 of those requiring revisions because they keep dislocating. And we've been working on this too to try to improve this by doing a better capsular preservation and repair. For many years, I've used the vascular sparing approach, but now we're doing a better and better capsular repair in the last 5 years. So we'll see if we can drive that down. We don't have enough numbers yet to tell for sure. All right, so now we're going to look to summarize up improvements in the 10-year implant survivorship. So here's a graph that's on my website. This was updated last year, so every year we update it. At 10 years, this is my Corin group, 89% at 10 years. These are Kaplan-Meier implant survivorships. This is the Biomet group. See how it's much improved, 95%. It's still cement. And here's the recent group. Pretty much flat line out here. And we're out to now to 13 years with 99% implant survivorship in this latest group since 2007. This is from a paper we did looking at the differences between men and women. Again, you can read it if you want on my website. So this is the difference currently between men and women. These were done before 2008, so they're further out, right? They're out to 15 years when we did the study, and this is after 2008. So we've done a lot of improvements that I talked to you about in that time. Most of those were in place by 2008. Not quite. There's still some wear failures there, but much better. We managed to improve women from 87 to 98% in this study. In the paper, we go through again exactly how we did that. Here's looking at the difference in gender, same paper. Here's women and men, the difference between men and women before we made all these changes, and this is after. So you can see that men improved from 96 to 99, so 3 percentage points improvement in 8-year equivalent, 8-year implant survivorship, but women went from 88 to 98%. So they had a much bigger 12% to 2% failure rate, so 10% percentage point improvement, or 6 times less. So all these improvements that we've made over the last 20 years have benefited both men and women, but because women were so much worse to start with, they have seen a much greater degree of improvement. So this is currently, and it's out to 13 years, it's the same. Current 13-year implant survivorship, over 5,000 cases, 99% implant survivorship. So I'm right up there with Derek McMinn right now with the uncemented group, 98% of women, and very large group of patients. And about half of these are under 50 years age. So in summary, advances in resurfacing have led to this being, I think, now the best implant survivorship ever reported for any sex or any age for any implant. 99% with 5,000 patients is just unheard of. It doesn't exist with total hip replacements. And as you see the ceramic on ceramic reports, 150 patients. I mean, it doesn't compare. We've shown that, I haven't studied this, but many people have studied this. The function is better because of stability, less residual unexplained pain, less thigh pain. There's bone preservation. There's a lower 10-year mortality rate. So hip resurfacing is advanced a lot in the last 20 years. And I did lie a little bit on my title. Women are now nearly equal to men. It's 99 versus 98, and that's statistically significant. So they're still a little lower than men, but we're almost equal now. And that's the end of the talk. Thank you.